Good afternoon, everyone. The next topic we will talk about is diabetes in pregnancy, which I'm sure you have all come across in your daily practice. The outline of my talk will be a bit of introduction and definitions, followed by risk factors for developing GDM and adverse outcomes of poor glycemic control in pregnancy. We will talk a little bit in detail about screening for diabetes in pregnancy and treatment targets, followed by postpartum follow-up, retinal screening, and I'd like to highlight what we have started last year, Diabetes in Pregnancy Registry, and open the floor for some questions. So, as you know, pregnancy is accompanied by insulin resistance, mediated primarily by the secretion of some diabetogenic hormones by the placenta. This includes growth hormone, placental lactogen, corticotropin-releasing hormone, progesterone, and prolactin. These, in addition to other metabolic changes, ensure that the fetus receives an ample amount of nutrients. Therefore, gestational diabetes develops during pregnancy in women whose pancreatic function is not sufficient to overcome the insulin resistance associated with the pregnant state. This graph will show us how the requirement for insulin increases as pregnancy progresses, and as you would see from 20 weeks on, the insulin requirement increases, indicating the development of significant insulin resistance. And the dotted line will show you what a natural woman's pancreas, a non-diabetic woman's pancreas will do. It will produce more insulin to overcome that resistance in the second half of pregnancy. However, the continuous line will show you what the pancreas of a diabetic woman will do, failing to meet demands in the latter half of pregnancy. And that explains why gestational diabetes is usually diagnosed in the middle or the second half of pregnancy. Historically, the term gestational diabetes has been defined as onset or first recognition of diabetes during pregnancy. However, as research developed over the decades, international diabetic organizations have more emphasized on the diagnosis being in the second trimester of pregnancy. So, gestational diabetes by definition is diabetes diagnosed during the second half of pregnancy, whereas overt diabetes or diabetes mellitus in pregnancy is often diagnosed very early in pregnancy and when the effects of insulin resistance are much less prominent than suggesting the presence of pre-existing diabetes prior to pregnancy. So what are the risk factors for gestational diabetes that we should be looking for? A personal history of pre-diabetes or impaired glucose tolerance is a strong one, as well as the history of gestational diabetes in previous pregnancies. We know that women who develop diabetes in pregnancy in one pregnancy are much more likely to have diabetes in the subsequent pregnancies and are 5 times more likely to develop type 2 diabetes later in life than the non-diabetic woman. Members of certain ethnic groups are at a higher risk, including Maori, Pacific Islander, and Indians. People with family history of diabetes, especially in the first-degree relatives, are also at high risk. A preconception BMI of more than 30 or weight more than 110% of the ideal body weight is a strong risk factor. Significant weight gain in early adulthood and in between pregnancies has also been considered risk factors. In previous years, it was thought that massive weight gain during pregnancy may be a risk factor, but studies have had controversial results. Older maternal age, mainly more than 30 years, is a risk factor, as well as previous poor obstetric history, including perinatal loss and macrosomia, and in addition to medical conditions that increase the risk of diabetes regardless of pregnancy, such as hypertension or the metabolic syndrome, people who are treated with steroids in addition to multiple gestation. So what is healthy weight gain in pregnancy? Weight gain in pregnancy is a normal physiological phenomena and should not be regarded as a bad result of pregnancy. In the first trimester, most women do not, in fact, gain weight and may even lose weight because of the hyperemesis. But most of the weight gain occurs in the second and third trimesters of pregnancy. And the amount of weight gain that we may regard as healthy depends on the lady's preconception BMI. You can see that if she has been underweight, then up to 18 kilograms of weight gain may be considered healthy. Whereas on the other extreme, if the woman's preconception BMI is more than 30, then we wouldn't want her to gain more than 9 kilograms during pregnancy. We all know that diabetes in pregnancy, if poorly managed, has certain grim adverse outcomes, including preeclampsia and gestational hypertension, in addition to polyhydramnios, macrosomia, maternal and infant birth trauma, need for operative delivery, perinatal mortality, in addition to fetal neonatal hypertrophic cardiomyopathy. Metabolic adverse effects, including hypoglycemia, hyperbilirubinemia, polycythemia, are contributing factors. So the risks of these outcomes increase as maternal plasma glucose levels increase. And this is regarded as a continuous effect. So there is no line between the high and low levels. Is a continuum of adverse effects that starts from mild increase in blood sugar levels to severe increase in blood sugar levels. I'd like to highlight the screening for diabetes in early pregnancy as a very important message for all of us because of the epidemic of type 2 diabetes and undiagnosed diabetes in our part of the world, as well as the whole world. This is part of the Ministry of Health guidelines about screening for diabetes in pregnancy. Every pregnant woman should be offered an HbA1c as a routine booking blood test before 20 weeks of gestation. This is because this test will help identify women with probable undiagnosed diabetes, as well as women who are at high risk of diabetes if they appear to be pre-diabetic or having impaired glucose tolerance. So what we do with that HbA1c level? If it is more than 50 or 50, then that meets the diagnostic criteria for type 2 diabetes prior to pregnancy, provided it is repeated in asymptomatic patients and proves to be persistent. And these women should be directly referred to the diabetes in pregnancy services in your local DHB, regardless of their gestational age. Women who have a lower HbA1c between 41 to 49 millimole per mole, these women are at increased risk of diabetes in pregnancy, and therefore they should receive dietary and lifestyle advice and should have an oral glucose tolerance test at 24 to 28 weeks of gestation. If the early pregnancy HbA1c is less than 40, then screening should take place again at 24 to 28 weeks of gestation. The lead maternity care should offer a 1 hour 50-gram oral glucose challenge test, which we usually call polyglucose test for all women who have HbA1c, which is less than 40. If that blood glucose level is 11.1 or higher, that lady is almost certainly gestationally diabetic, and therefore she has to be referred to the diabetes in pregnancy service. However, if the polyglucose test resulted in a blood glucose between 7.8 and 11, that woman should proceed to a formal oral glucose tolerance test with the cutoffs of fasting of 5.5 or higher, or post 2-hour blood glucose 9 or higher being diagnostic for gestational diabetes. So these women should be referred to the local diabetes in pregnancy service as soon as possible. So what should we do after these women are diagnosed with gestational diabetes? All of them should be offered immediate contact with a service that specializes in DIP and that offers tailored care in addition to the care provided routinely by their LMC. The blood glucose targets are a fasting blood glucose of less than 5 and a 2-hour postprandial level of 6.7 or lower. And it is clear that these targets are more strict than outside pregnancy. And that is because fetal outcomes have showed us that keeping the blood glucose level control at this strict level has the best outcomes. Women with poor glycemic control, meaning that at least 10% of their blood glucose levels are higher than target, should be offered pharmacological therapy with metformin and/or insulin. And I'm sure this is well known to most of you, but may I have a plea to all my colleagues in primary care not to stop metformin when pregnancy is confirmed. There are still some thoughts that it may not be safe, but we have been practicing providing metformin to our diabetic ladies for more than 10 years now. After Janet Rowan's study, the MEG trial proved that metformin is safe in pregnancy for maternal and fetal outcomes. Treatment should be reviewed by a specialist, possibly through a remote consultation, where more than 10% of blood glucose measurements exceed targets in 1 week. Postpartum follow-up is also an important aspect of care for these women. Women who were diagnosed with gestational diabetes should be informed about the risks of gestational diabetes in future pregnancies and the risk of developing type 2 diabetes later in life. They should be offered lifestyle advice and an HbA1c measurement 3 months postpartum, and if normal, annually thereafter. As you know, HbA1c of 50 or higher confirms the diagnosis of type 2 diabetes, and if the HbA1c is between 41 and 49, women will need a repeat test in 3 months. The 6 weeks postpartum oral glucose tolerance test is almost obsolete now and should not be relied on. So I'm sorry if this flowchart doesn't project well, but basically it summarizes what we discussed about the care of pregnant women from early screening to follow-up postpartum. So all pregnant women who have type 1 and type 2 diabetes or have an early screening HbA1c of 50 or more should be referred directly and as early as possible to the local diabetes in pregnancy service. If their HbA1c is less than 40, screening should be repeated at 24 to 28 weeks with a polycose test or a glucose challenge test. And if it is abnormal, then they should proceed to an oral glucose tolerance test. Unless the polycose test is more than 11.1, then they should be referred directly to the diabetes in pregnancy service. All women with gestational diabetes should have postpartum HbA1c at 3 months. I would like to highlight the importance of retinal screening in pregnancy because we know that the risk of progression of existing diabetic retinopathy is high during pregnancy, especially with poor glycemic control. And although it has been included in the Ministry of Health guidelines that diabetic women should be referred for retinal screening, we have been not following that practice very well. So the screening guidelines for diabetic retinopathy is that all the following pregnant women should be screened in the first trimester: women with known type 1 or type 2 diabetes, women not known to have diabetes prior to pregnancy, but their screening HbA1c in the first trimester proves to be 50 or higher, or patients when they develop gestational diabetes after 20 weeks of pregnancy. These women are not at risk of diabetic retinopathy, so they do not need to be screened. So in a nutshell, women with type 1 and type 2 diabetes or women with diabetes early in pregnancy should be referred for diabetic retinal screening. I would like also to draw your attention to the Diabetes in Pregnancy Registry. This is a joint project between counties Manukau Health with support from the Freemasons Foundation at Middlemore Clinical Trials. We joined together to start a registry which is first of its kind for diabetes in pregnancy to improve diabetes screening after pregnancy. It basically entails a clinical nurse specialist nurse meeting our diabetic women in their first specialist assessment appointment at the Diabetes in Pregnancy Clinic and asking them for their permission to gather their clinical, ethnic, biological, and demographic data during the pregnancy. This will help a lot in providing data for future research about the outcomes of diabetes in pregnancy care. Approximately 1,500 women attending the DIP clinic over the period of 2017 to 2020 were invited to participate. Once women agree to join the registry, the woman's GP will receive automatic electronic notification to offer diabetes screening 3 monthly after delivery and every 12 months after that. And we hope that this will significantly improve the early support provided to at-risk women. The registry will also be a rich source of information to support diabetes research. While the initial rollout of the registry will be focused on women from counties Manukau area, it is hoped that lessons can be applied nationally and potentially further afield. So far, the first lady who signed was in June 2017. 736 pregnancies in the prospective cohort and just over 2,000 pregnancies in the retrospective cohort. And that will total 2,781, which accounts to 96% of involvement. In 2018 alone, there were 750 pregnant women referred to the Diabetes in Pregnancy, and proportion of these women with GDM who had an HbA1c of 50 or more at 1 year was almost 23% of all women with GDM and 30% of women who had prior GDM. These data reflect the 2,000 plus women in the retrospective cohort and not the prospective cohort. The recall rates in pre-registry cohort, as you see, are not that pleasant, but we aim to improve them with the registry. So the entire cohort, there was only 30.9% recall at 3 months, higher in type 2 diabetes, and prior GDM was lower. Happy to receive any questions, and please keep your pregnant women in mind and screen them for diabetes as early as possible.
I would like, if anybody knows me, they know my interest in contraception. And I would like to remind everybody that if you have a woman of reproductive age who's a diabetic, and particularly a poorly controlled diabetic, think contraception, think LARCs, long-acting reversible contraception, think getting good control before she starts that pregnancy, because we still see serious complications and abnormalities in the fetus from uncontrolled diabetes at conception. So do keep that in mind, please. Sorry, just...
Completely agree. And tubal ligation comes at the very end.
Thank you very much
You're most
for your
welcome.
talk. Thank you.